Greetings to every distinguished delegate present here. Recently, a case in the clinical setup stumped me because I casually biopsied the lesion expecting to encounter an oral squamous cell carcinoma just like any other Indian oral pathologist would expect on the table. However, I was taken aback when I found it to be chondromyxoid fibroma in the mandible in a patient with a history of treated breast cancer. Let us jump into this case now. A 45-year-old female presented with right-sided pain and swelling in the lower jaw, persisting for the previous 3 months. The pain was intermittent in nature and exacerbated during eating and at night. The patient disclosed a history of surgical intervention for breast cancer a decade ago, followed by radiotherapy. However, no reports were available to confirm the histological subtype or staging of the tumor. Clinical examination revealed a localized ovoid growth with proliferative characteristics and a firm texture. It was firmly attached to the underlying bone extending from the lower right third molar to the canine region. While lateral jaw movements were compromised, the patient exhibited normal mouth opening with no palpable fibrous bands in the buccal mucosa. Oral squamous cell carcinoma and metastasis from breast cancer were under consideration for the expected diagnosis. Reactive fibrous hyperplasia was particularly considered as the patient reported a possible reduction in the size of the lesion over the previous week. Radiographic examination revealed an expansile radiolucent lesion in the corresponding mandibular region mimicking horizontal bone loss involving the alveolar ridge and the entire buccolingual thickness of the mandible. This was suggestive of buccal and lingual plate resorption. Root resorption of the premolars was also considered as evidence of caries onset in them was not evident. Incisional biopsy yielded 2 firm soft tissue fragments which were brownish white in color. They were too small to be further grossed and hence they were embedded intact in the same wax block. Histopathology revealed lobulated architecture with hypocellular centers and hypercellular peripheries. The periphery of the lobules exhibited variably myxoid to chondroid stroma with stellate fibroblast and multinucleated giant cells. Thin bundles of highly vascularized connective tissue separated these lobules. Several subepithelial microabscesses can be noted here, and they were suggestive of acute inflammation. This phenomenon could have resulted in the apparent reduction in the size of the lesion, coinciding with the patient's reported use of mouthwash, which she revealed later. Now we can find the hypocellular centers and hypercellular peripheries here. And again we find some small foci of calcification within the tumorous lesion. Nuclear pleomorphism, mitotic figures or cellular atypia were not observed. These plump to spindle-shaped chondrocytes with indistinct cell borders were disposed in sparsely cellular lobules of myxoid matrix. The chondroid matrix is however not evidently observed in this particular photomicrograph. A pathological diagnosis of chondromyxoid fibroma was given. Though curettage has been widely suggested, an en-bloc resection was intended to be performed owing to the 25% recurrence rate observed after curettage. However, in our case, the patient declined further treatment and was lost to follow-up, precluding any further investigations. The WHO defines chondromyxoid fibroma or CMF as a benign tumor which is characterized by lobules of spindle or stellate cells with abundant myxoid or chondroid material. Accounting for less than 0.5% of bone tumors, they show a slight male predominance and common metaphyseal location. Chromosomal 6 abnormalities have been implicated in its etiology. Chromosome 6 carries genes such as the BMP6, Col9A1, Col10A1 and IGF2 which are involved in normal cartilaginous development. Oncogenic activation and overexpression of glutamate receptor gene has also been identified as the other causes of CMF. This benign locally aggressive tumor is commonly found in patients in the second or third decade of life. However, our patient was 45 years old. The male to female ratio is 2:1 except when the facial bones are involved, as women then prevail in a 2:1 ratio. When symptomatic, they are associated with a long history of chronic local pain, swelling, edema, and possibly a palpable soft tissue mass resulting in restriction of movement as in our case. Given its rarity, an early differential would seldom, if ever, have CMF as the primary diagnosis. The radiological appearance is characteristic but misses specificity. Osseous destruction, well-defined lobulated margin, partial cortical erosion and septations were usually observed. In our case, the cortical outline was destroyed and there was soft tissue infiltration. Now, lesions such as chordoma or chondrosarcoma could present with calcifications within the radiolucency. But however, in CMF, though foci of calcification are observed, they are frequently microscopic and are rarely visible on imaging. Osteosarcoma can easily be identified using malignant radiographic features such as the sunburst appearance. Now, to assess the soft tissue involvement, an MRI could be ideal. However, a detailed histopathological evaluation becomes crucial in making the prognosis. While numerous ossifying lesions could feature in the differential diagnosis, when there is a predominant chondroid component, then our mind will tend to focus only on chondrosarcoma and chordoma. The chondrosarcoma can be differentiated from CMF by the presence of mitosis, nuclear atypia, invasive growth pattern, and liquefactive changes in the stroma. The myxoid areas tend to become more fibrotic during tumor maturation. Meanwhile, chordomas can be differentiated by their phyllaciferous cells with vacuolated eosinophilic cytoplasm. The chondromyxoid fibroma, like osteosarcoma, may also show resemblance, especially in lesions with malignant radiological features. However, the Vimentin positivity, S100 negativity, and the elevated ALP and lactodehydrogenase levels can help us distinguish it from other fibroosseous lesions of the jaw. Cosmetic and functional concerns in craniofacial lesions have often led to the choice for curettage in tumor excision. However, the presence of tumorous microlobules deep in bony crevices could prove difficult to removal by curettage, pushing a chance for malignant transformation. Surgical en bloc resection is hence preferred to overcome this risk. Of the two cases of CMF where malignant transformation has been reported, one proceeded to malignant fibrous histiocytoma and the other to fibrosarcoma. The latter had previously undergone radiotherapy. However, contrasting results have been observed on the therapeutic significance of radiotherapy because some authors have suggested postoperative irradiation as an attempt to reduce the recurrence. Polymethyl methacrylate bone cement has been used in place of bone grafts for reconstruction to avoid the morbidity, provide biomechanical stability, and destroy any residual tumor cells by thermal injury. While exceptionally uncommon, CMF occurrences in the jaws have been documented. Despite similarities in imaging to chondrosarcoma and chordoma, distinguishing CMF through histopathology is crucial for effective treatment. Although curettage in radiotherapy might appear essential for inaccessible tumors, opting for complete en bloc resection is preferred to reduce the likelihood of recurrence. These are my references. Thank you for patiently listening to me.